This time of the year, I've been trying to keep fewer but better things in my closet, things that are well made and easy to wear all the time. And that's why I keep going to Quince. I actually recently got a few pieces of Quince for my husband for our anniversary. And my gosh, at one of the kids' birthday parties, he could not stop getting compliments from the other parents. And that made me so happy for him. What I really love is that they have high quality fabrics like 100% European linen with prices that make sense. I was also wondering how their prices are 50, 60% less than similar luxury brands. What Quince does differently is that they work directly with ethical factories and cuts out the middleman. So you're paying for quality, not the markup. And the materials are also very breathable and comfortable. So if you want to refresh your wardrobe with staples or better quality, then give Quince a try. Go to quince.com/CoreIM for free shipping and 365-day returns. And it's also now available in Canada too. So go to quince.com/CoreIM for free shipping and 365-day returns. Quince.com/CoreIM. And with that, let's get back to the episode.
I think one has to be vigilant that on occasion, this curious cell can indeed contribute to and cause tissue damage. And it's up to us to be cognizant of that risk, evaluate appropriately to try to determine that risk, and then ameliorate it in an intelligent and rational manner if we can.
Welcome to the CoreIM 5 Pearls podcast, bringing you high-yield, evidence-based pearls. I'm Dr. Shrey Trivedi, and I'm joined by...
Hi, I'm Gila Gershon, an internal medicine resident at Beth Israel Deaconess Medical Center. Today's episode is all about peripheral eosinophilia.
Yes, and to help us sort through this, we spoke to experts in the world of allergy and immunology, hematology, and pulmonology, and to dig into this topic in a way that I'm biased, but I feel like is way more approachable than what I knew before.
Agreed.
Hi, I'm Dr. Peter Weller, Chief of the Allergy Division and former Chief of the ID Division at the BI Deaconess. And I've had a long-standing interest in eosinophilia.
Hi, I'm Jason Freed. I'm a hematologist at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston.
I'm Trevino Cathota from Pulmonary and Critical Care at University of California, San Diego. I'm a professor of medicine there. I have a practice that focuses on eosinophilic diseases.
And as always, please pause after each of the following pearls and test yourself.
Because the more you test yourself, the deeper your learning gains.
Pearl 1, thresholds and why we care. Why do we care about eosinophilia, and when does the eosinophilia become dangerous?
Pearl 2, eosinophilia and atopy. When can asthma, allergic rhinitis, or eczema explain eosinophilia, and when should you worry something more systemic is going on?
Pearl 3, medications. Which medications most likely cause eosinophilia, and when is it safe to monitor versus when you need to stop?
Pearl 4, infections and parasites. How do travel, immigration history, and diet guide your infectious workup?
And finally, Pearl 5, steroids and malignancy. How do steroids affect that eosinophil count? And why do we need to think about neoplastic causes of eosinophilia before we treat? Okay, let's start big picture here, Hila, and maybe the elephant in the room. Why should we even care about eosinophils to begin with?
Shreya, I had the exact same question, and that was a big motivation behind why I wanted to learn more about this. So we care about eosinophilia for two main reasons. First, if the eosinophils get high enough, they can cause direct organ damage, regardless of why they're so high. The second reason is that an elevated eosinophil count can be that first clue that something more serious is going on in the body.
Ah, amazing. Okay, so before we get into the clues about what that eosinophilia might be telling us, let's make sure we're all on the same shared language. What is eosinophilia? And then when should we pause? And particularly, can you help me understand the numbers in the EMR? There's percentages, there's absolute values, there's decimal places.
Definitely. Eosinophilia is an absolute eosinophil count greater than 500 eosinophils per microliter. Unfortunately, in most electronic medical record systems, this will not show up as 500, but rather 0.5. So since the units are different, you'll need to multiply by 1,000 anything you see in the EMR to get the eosinophils per microliter.
So glad you said that because I also even get confused. Do I look at the percentage or do I look at the absolute one? And it so sounds like I'm looking at the absolute EO count, and we kind of ignore the percentage. And then, yeah, I guess we just have to like translate like decimal points.
Right. So for absolute eosinophil count greater than 500 or greater than zero point 0.5 in our electronic medical record system, we're starting to put on our detective hats. But when we're reaching an absolute eosinophil count greater than 1500 or 1.5, we get into hypereosinophilia territory. And that's when we need to get vigilant and do more than just put on our detective hats.
Hypereosinophilia just means their absolute eosinophil count is above 1500. That we just arbitrarily decide if it's above that, it's hyper. Okay, fine. But what's hypereosinophilic syndrome? Hypereosinophilic syndrome means you have an absolute eosinophil count above 1500 and you have some end organ manifestation that is being caused by the elevated eosinophils. It's pretty rare to have sort of end organ manifestations with an absolute eosinophil count less than 1500. Between 1500 and 5000, it gets tricky because you can definitely have some life-threatening manifestations in that category. And then when you get above 5,000, and then especially like the higher you get, the more likely that you are to develop some serious end organ manifestations from the non-specific effects of having super high eosinophil count.
Okay, so it sounds like if the eosinophil count is high enough, particularly above 1500 per microliter or 1.5 in the EMR, then we worry about that directly causing some end organ damage, regardless of the cause.
Exactly. Hypereosinophilia is just the number, just the absolute eosinophil count greater than 1500 or 1.5. Now, hypereosinophilic syndrome, that's a clinical diagnosis. That's hypereosinophilia plus end organ damage, which is more likely to occur when the eosinophil count is above 1.5.
Okay, so it sounds like when there's too many eosinophils, these crowded eosinophils degranulate in the blood and in the tissue, and that can lead to the end organ damage. And unfortunately, that end organ damage can be in any organ: the heart, the skin, the lungs, the GI system.
Yeah, I once had a patient who presented with right sided weakness and was found to have embolic strokes. Her eosinophil count was 17,000 or 17.0 on Epic, and her troponins kept rising. She never had any chest pain, shortness of breath, but as part of her workup, we got a cardiac MRI. That showed signs of fibrosis, which was really concerning for eosinophilic myocarditis. Because of all the inflammation in her left ventricle, she developed a thrombus that then embolized to her brain and led to these stroke symptoms.
Oh my. Ugh. You know what I'm so struck by is that patient had no symptoms, right? That eosinophilic myocarditis was clinically silent. Gosh, like there was no symptoms related to that cardiac dysfunction.
Exactly. And my takeaway from that is when patients have an eosinophil level above 1500 or 1.5, we need to be vigilant in evaluating for eosinophilic myocarditis, regardless of the symptoms. We should get troponins and EKGs. And I even spoke to some cardiologists who recommend getting an echo upfront too to evaluate for that thrombus formation.
So helpful. So trope, EKG, plus minus echo when the eosinophil count is greater than 1500 per microliter or 1.5. Okay, what about the other organs, right? Do we do anything else to screen for other end organ damage in the body when the EO count is that high?
We should definitely get a basic metabolic panel and liver function tests to evaluate for any renal or liver involvement. But the rest of the body, it's really having that vigilance. Like you need to do a thorough review of systems to identify any new pulmonary or GI symptoms, do a physical exam to look for any rashes or any neurosigns.
Okay, so that's helpful in the context of anyone who has an EO count greater than 1500 or so. But I guess the other question is like, does it matter how high the eosinophil count is above that 1500 threshold? Like, is someone with an eosinophil count greater than 3000 more likely to have end organ damage than someone than 1500 eosinophils per microliter?
Oh, Shreya, if only it was that straightforward. Though there is a higher risk with more elevated eosinophilia, there's not a one-to-one relationship. This number cutoff of 1500 gives us an idea of a patient's risk of an organ damage, but peripheral eosinophil counts, which is what we measure on a CBC, does not correlate with the damage that eosinophils can cause in the body.
There's no perfect correlation between magnitude of blood eosinophilia and risk of cardiac damage or other eosinophil mediated grief. With the imprecision of measuring eosinophil numbers and the fact that what we can sample is the circulating blood pool of eosinophils, we don't know what's going on in the marrow. We don't know what's going on in tissues.
Understanding the life cycles of eosinophils is really helpful to explain this. Eos spend only about 25 hours of their lifespan in peripheral circulation, but then spend days or even up to weeks in the tissues. They call eosinophils tissue dwelling cells for a reason. So you can imagine the sample that you're getting in your AM labs is only a snapshot in time and misses the full distribution of eosinophils in the body.
Yeah, man, that idea that the EO count that we see in our EMR is just a snapshot and that these eosinophils are mostly, as you said, tissue dwelling, like they're mostly in the tissues and not in the blood. I guess that makes sense why in like conditions like eosinophilic esophagitis, they're basically eosinophils that are just in the tissue in the esophagus, but there's no peripheral eosinophilia.
And at the same time, there can be peripheral eosinophilia without tissue damage. This adds another layer of complexity to the already complicated topic of eosinophilia.
Oh, man, awesome. I'm with you. I'm getting this. Thank you so much, Kayla, for doing this. So, maybe if I can summarize kind of our first chunk, our first pearl, it's that we care about eosinophilia, particularly that's defined by greater than 500 eosinophils per microliter or zero point 0.5 in the EMR. We care about it for two reasons. One, if the eosinophils get high enough, usually above 1500 or 1.5 in the EMR, that can directly cause end organ damage, regardless of the cause.
And the second reason we care is that the absolute eosinophil count is a clue that something else more serious is going on. So let's put our detective hats on for the rest of these pearls.
All right, so let's say we have a patient whose eosinophil count is 750. So in the EMR, it would show up as 0.75. To be on the safe side, we think about end organ damage. There's no symptoms, there's no lab abnormalities, nothing scary. Like, can we just ignore this 750 eosinophil count? Can we just like close our eyes and hope it goes away?
Short answer, no. As we mentioned, even without end organ damage, eosinophilia can still be a signal that something else is going on. So we still need a framework to figure out why the eosinophils are so high.
There is a very popular mnemonic for the causes of eosinophilia that I have actually found very helpful in my practice, and that is NAACP.
Okay, so NAACP is a helpful mnemonic, but it misses an important etiology of eosinophilia and also includes a name for EGPA we don't use anymore. So I propose a new mnemonic, Camp E or Camp Eosinophilia.
Awesome. Tell me more, Hila.
So envision 5 tents around a bonfire in the woods of Camp E or Camp Eosinophilia. Each of these tents represents a different etiology. So C is for cancer, A is an extra large tent with room for both atopy and adrenal insufficiency, M is for medications, P is for pathogens, and E is EGPA. The bonfire in the middle represents the inflammation that is caused by having too many circulating eosinophils.
I love that, but also humbling, right? Because like everything from cancer, atopy, adrenal insufficiency, meds, parasite. I mean, I appreciate a good list. Keeps us from missing stuff, but lists are also just lists. And how do we prioritize, one thing from another?
I feel you on that on such a deep level. So I thought it would be a really good idea to go through the most common causes of eosinophilia and dig through some nuances within each.
When I'm seeing an outpatient for peripheral blood eosinophilia, one of the first questions I'm asking myself is, do they have a disease known to be associated with peripheral blood eosinophilia? Number two, is the eosinophilia mild? And therefore, I can just probably connect it to that disease known to be associated with eosinophilia. And number three, is there anything else going on with them that needs to be explained? Or is this really just an incidental abnormality that we're trying to connect? And if it's just an incidental abnormality, they're doing fine otherwise, and we've got a diagnosis we can connect it to, and it's mild, I'm usually done there.
Okay, so if we're meeting a patient in clinic who has mild eosinophilia, and then the conditions I'll be thinking about are the things that fall in that atopic bucket, right? Allergic rhinitis, asthma, atopic dermatitis. And one thing that I learned from our peer reviewer was that even eosinophilic GI diseases like eosinophilic esophagitis falls under the atopy umbrella.
For relatively not high grade eosinophilia, like in the kind of that 500 to 1500 range, I'd say, top things that they often are in those patients are some sort of atopic cause. Atopy is very common in the population. So that's what, common things being common.
As I was learning more about this topic, I kept seeing this relationship between eosinophils and allergic conditions, and I kept wondering why. Turns out, atopic diseases are driven by damage to the epithelium, which leads to inflammation. This inflammation leads to the migration of type 2 helper cells, and they produce a ton of IL 5. If you remember from boards, IL 5 is super important for eosinophil maturation and their survival.
So IL-5 is also produced by lymphocytes, CD4 type 2 lymphocytes that, those cells that are kind of canonically or classically regulated in allergic conditions. And that's why eosinophils are up in these atopic conditions in many patients with atopy is that that's driven by some excess IL-5.
IL-5, wow. I have not thought about that in a minute, but makes me think like, if someone has a really bad allergy flare or an asthma exacerbation, maybe their IL-5 will like go crazy and then their eosinophil count will be proportionally that much higher.
That's a good thought, but unfortunately, no.
Ah,
You could be well controlled asthma and still have an eosinophilia.
You can have eczema or atopic dermatitis or eosinophilic gastritis that is relatively well controlled and still have eosinophilia. So, eosinophilia is not a marker of disease activity, and IL 5 is not a helpful lab to send.
what a humbling cell in our bloodstream. I just wish it was like a one-to-one with the eosinophil count interpretation. I guess what I'm worrying about is that, say I have a patient who has a mild eosinophil count and they have something in their chart like asthma, allergies, atopic dermatitis, then my worry is that I'm just going to write off that eosinophil count and not think of the other things in that can't be pneumonic, right? Like, I don't want to miss parasite. I don't want to miss cancer.
I don't either, and I live with those same anxieties, but common things are common. What you do bring up, though, is a really great point that we need to keep a healthy dose of curiosity because systemic conditions like EGPA or eosinophilic granulomatosis with polyangiitis often start with eosinophilia and asthma.
But I think one still has to keep in mind that is there something else developing? An example would be what used to be called the Churg-Strauss syndrome, EGPA. That can be a process where, for adults that manifest by adult onset asthma, sinusitis, and then the vasculitis manifests later. So it's a situation where I think you can say, yeah, can asthma give you eosinophilia? Yes. But can you close the book necessarily in that individual? Not if something else is developing that makes you worried about a vasculitic process.
So, when there are multiple systems involved with signs of glomerulonephritis and asymmetric neurologic findings like mononeuritis multiplex, it raises the possibility of vasculitis. And if those are present, you need to consider EGPA, formerly known as Churg-Strauss disease, as a potential etiology.
I got called in MICU on a weekend night, and it was a gentleman who ended up perforating his bowel. And in retrospect, it was a vasculitis. It was EGPA. He had been referred about a year and a half before. He probably had some abdominal pain, but he had a CT scan and he had a hypernephroma. So he was sent to us for a surgical resection. At that time, he had an eosinophilia. People say hypernephroma, eosinophilia is no link. Let it be. But in retrospect, he had Churg-Strauss syndrome, EGPA. And what did him in was ultimately was small bowel vasculitis. The eosinophilia, in retrospect, was a clue to that. And probably some of his abdominal pain was his incipient GI vasculitis that then led to the CT scan, which gives you the diagnosis of hypernephroma, true but not related.
Wow, that case really highlights that mantra of staying curious. So, I guess what I'm taking away is in a patient with asthma or sinusitis and other unexplained symptoms like that vague abdominal pain in the case we just heard, or the classic kind of polyp on exam, or maybe there's unexplained opacities on lung imaging or abnormalities in their neuroexam or in their urine studies, we can think about EGPA. And Gila actually found this. There's these Euler criteria that can help us think through the diagnosis. And of course, we can always reach out to our rheumatology and allergy colleagues that can help us make this very complex diagnosis.
And so, to recap, when someone has unexplained eosinophilia without localizing symptoms, one of the first questions to ask is, do they already have a condition that's known to be associated with eosinophilia? Atopy really is one of the most common causes of eosinophilia, driven by damage to the epithelium and subsequent inflammation. But eosinophil counts are not associated with disease activity.
I still can't get over that. I wish it was a one-to-one. And then the other thing is that when, the explanation seems benign, I think we can all stay a bit curious. Make sure we're monitoring over time, watch out for any red flags that kind of come up. And of course, eosinophilia might be a first clue that something bigger might be developing down the line.
So we've talked about atopy as a potential source of eosinophilia, but our third pearl is truly something we see all the time.
Medications.
I think one of the most important things that you can do as a generalist is to take a very thorough medication history, because medication related eosinophilia is so extraordinarily common, both in terms of outpatients and both in terms of inpatients. And the diagnostic test for that is a really good medication history, which is not easy to do. And it's actually like sometimes it's like so easy to like click, 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 order, you know, echo, order this, order that, order refer. But like, you know what's hard? Spending 15 minutes in the chart, looking at when they got each different antibiotic over the past 2 weeks and seeing which one might make sense timing wise as the cause of their dress syndrome. But guess what? That's actually what's really going to solve the case, not necessarily sending off this $1 million workup for a bunch of things that don't make sense. Because if they acquired eosinophilia in the hospital, it is almost certainly related to a drug you gave them. And so doing a really good drug history is so essential.
There is nothing like a good history and chart review to figure it out. But yes, it takes time. And we do have to be thorough, right? Because that eosinophilia might not happen in front of our eyes, but after discharge.
The group at MGH looked at 824 consecutive patients where they were going to be getting extended courses of IV antibiotics, often about 6 weeks. And when they looked, 25% of their patients developed some degree of peripheral blood eosinophilia, absolute eosinophil count greater than 500. They saw eosinophilia with basically every antibiotic. Of course, vancomycin, linezolid, like penicillins. But essentially, if you think about what antibiotics are, they're large natural products. They ended mycin, right? Like we got them from microorganisms. And our bodies are sort of trained to treat such things as foreign, right? These like large macromolecules. Like we, of course, want to be having an immune response to these large macromolecules. And so drug related eosinophilia is really common with these large macromolecules like antibiotics.
So antibiotics are a big cause of drug-related eosinophilia, but they're not the only ones. Some commonly implicated medications besides antibiotics include NSAIDs, anticonvulsants, and allopurinol.
Homeopathic preparations at times have elicited eosinophilia. The notable example from some years ago is batches of contaminated L-tryptophan that people took for a number of reasons, for sleeping and this and that. And
If you work in healthcare, you might already know this. And in case you don't, it is Nurses Week. Time to shout out the incredible people we have the privilege of working with every day, and also who happen to be some of the best humans you and I know. And to celebrate, Figs just dropped new limited edition colors and styles you cannot not love. And best of all, everything's 20% off during Nurses Week. From scrubs to outerwear to footwear and beyond. Figs really gets what healthcare professionals need to look sharp, feel good, and with that mentality, they can just take on about anything. So if you're in healthcare, don't miss out on 20% off for Nurses Week happening May 6th through May 12th. Go to wearfigs.com. That's 20% off during Nurses Week at wearfigs.com.
they developed the eosinophilia myalgia syndrome, mechanism which is still not understood. It was the L-tryptophan that they were taking. And in some of those individuals, the medication history was not volunteered because they weren't thinking about their nocturnal L-tryptophan dose as a medication. Doctor didn't prescribe it, took it on their own.
So yes, ask about supplements, ask about over-the-counter meds or quote unquote natural products, whatever will jog our patient's memory on the other things that they're taking. But I gotta say, Gila, it seems like almost every medication can cause eosinophilia. And the hard part is to figure out which one, right? Like I can imagine a situation where someone's on antibiotic, but also taking natural products.
Very fair, and most of our patients are on more than one medication at a time. So you're right that any number of meds can be the culprit. And on top of that, it's sometimes tricky to pin down which one because drug related eosinophilia isn't an immediate allergic reaction.
In most cases, the mechanism that drives the eosinophilia elicited by medications is really not well understood. It's not an IgE type allergic reaction, probably some manifestation of cell mediated immunity. And it can develop after someone's been on a medication for a period of time. It may not become apparent right away.
So, because of the cell immunity, the time from when you start a medication to when you develop peripheral eosinophilia can really vary by what medication it is and whether a patient has seen that medication before.
Ugh, that variation is so annoying to me because I wish, again, it was like a clean timeline, right? Like drug exposure, and then 1 week later, eosinophilia.
We have some rough guidelines from one of the studies that showed that the median time from medication start to isolated peripheral eosinophilia is anywhere from 1 to 21 days, but even that's quite a big range.
Right? So I guess maybe the practical kind of takeaway is to ask our patients, hey, what medications have you changed in the past month or so?
If something was started recently and we know they didn't have any eosinophilia a year ago, but now they have one, it begins to point the finger potentially the newly started medication.
Okay, so let's say the timing of a new medication starting and that trend of the absolute eosinophil count going up kind of works out, and we have a good sense of, okay, it was this medication doing it. Does that then mean automatically we have to stop it?
Not necessarily.
If they just have isolated peripheral blood eosinophilia that is relatively mild, those patients can usually just be followed. And if that's really the best antibiotic for them, we'll often just continue the antibiotic because that's the safest course of action is to actually treat their infection, not to worry about an asymptomatic lab abnormality.
As long as there's not eosinophil mediated damage to tissues, I can continue to monitor that patient and follow them. Balance the need for the medication versus the easy choice is terminating it. At times, hopefully, patients were started on a medication for a reason. So that again comes up in patients who are, say, on long-term antistaphylococcal agents, semisynthetic penicillins. They not infrequently will develop a low-grade eosinophilia. They need it for what is potentially a life-threatening endocarditis or whatever, osteomyelitis, and one would like to continue to ride with that. One can, as long as one's not missing something that is a reflection of eosinophil-mediated tissue damage.
Okay, so isolated asymptomatic eosinophilia, we can often monitor.
But that isolated qualifier really matters because what we're always watching for is DRESS, which stands for drug reaction with eosinophilia and systemic symptoms.
Mm. And those systemic symptoms, the SS and dress, is not subtle, right? Our patients are going to be having fevers, morbilliform rash, facial edema, lymphadenopathy, hepatitis, AKI, a whole storm.
Right, but it's just important to note because DRESS is treated very differently than isolated eosinophilia. In DRESS, the offending agent has to be stopped immediately, and patients often require further immunosuppression with steroids or other medications.
Yeah, I think this is why we have to closely monitor, right, for end organ damage. And I think for spaced repetition, right, we're going to be looking for troponins. We're going to get an EKG to see if there's any low voltage or any new arrhythmias. We're going to get LFTs. We're going to look at the kidney function and, of course, do a careful skin exam.
And if you're suspecting a drug related eosinophilia, I'm going to add to that list a urinalysis. We're going to be looking for sterile pyuria or white cell cast that would be concerning for interstitial nephritis.
Yeah, thanks for adding that.
And so now that we're going through it, I'm really starting to understand why our patients on long term antibiotics are in quote unquote safety labs. It's
Yeah.
one of the reasons, at least, is to monitor for this development of DRESS syndrome from peripheral eosinophilia. DRESS, we should just keep in mind, develops around 2 to 6 weeks after medication initiation.
Okay, so maybe to summarize the takeaways when it comes to medications causing eosinophilia, I think we know our usual culprits that can do it. Antibiotics, anti-seizure meds, allopurinol, NSAIDs. Those are the typical ones, and then it can happen days to weeks from starting.
And it's important to remember that mild, isolated eosinophilia doesn't always require stopping the drug, but you really have to be vigilant and monitor for end organ damage or DRESS.
Okay, so now on to my favorite pearl, and I think the most practice changing one for me. We did Atopy, we did medications, now onto the P of the camp, E mnemonic, P for pathogens. And here we're really talking about infectious causes.
I'll be honest, Rhea, before this episode, I thought I was doing such a good job with travel history. I'd ask, any recent travel, get a no, and move on.
Oh, same. But Dr. Weller taught us that that is not enough.
In terms of travel history, is we often will ask where people been recently. We also have to remember that we should ask about their emigration history because there are people that have come from areas where some of especially the GI parasites may be endemic, who have not gone back to their home. They haven't been in Costa Rica for 10 years or Puerto Rico for 10 years. So travel history is negative. No, they have to include emigration history because, especially strongyloides, which can be a chronic infection that uniquely auto infects, so it can perpetuate its life cycle, at times subclinically or pauciclinically, and that is germane. And occasionally, someone will develop disseminated strongyloidiasis when they're immunosuppressed, and that distant immigration history has been overlooked. And the nominal travel history last couple of years, no, I haven't gone back to my native country. So history is important.
Okay, so a good travel history isn't just about, okay, did you have any travel recently? Especially because of a parasitic worm, strongyloides, that can perpetually auto infect.
Yes, strongyloides is special in that it can complete its whole life cycle in the human host. That's why the infection can persist for decades after the exposure and can cause this low-grade eosinophilia in immunocompetent patients.
Yeah, and then if a patient does become immunosuppressed, then the strongyloides can turn into a very life threatening hyperinfection.
So we need to ask about where they were born, where they lived, and every stop along the way.
And also, in terms of travel, where in the world have they been? One patient I got called on in marked eosinophilia. He was a PhD student who had been working in Madagascar, which curious, but marked eosinophilia, and try to think about the parasites that cause marked eosinophilia in Madagascar. And nothing jumps right out. But it turned out he had spent time in West Africa, where some of the filarial parasites are present. And indeed, he had what is Loa Loa.
And then there's another part of the history we often forget: diet.
A corollary of a travel history is a dietary history. If they've been traveling, or even if they haven't been traveling, anything that they might have consumed. Trichinosis would be an example of a parasite that causes marked eosinophilia. And if they had consumed, say, wild bear meat in Canada, in Maine, or still in Central Europe, they can develop trichinosis.
That is a great point. We need to ask our patients, have they eaten any undercooked foods like seafoods, wild meats, or anything else, right? This is not something our patients are going to volunteer unless we directly ask them.
So, parasitic infections, especially helminths or worms, account for most infectious causes of eosinophilia. But it's really important to keep in mind that viruses like HIV and fungi can also cause eosinophilia.
A patient that I was called about started on an antibiotic for pneumonia, had an eosinophilia. So the question to me, does antibiotic X cause eosinophilia? So I started reading up. I didn't think so, but it couldn't find case reports. But it turned out what was not given to me was the patient's travel history. He's a middle-aged male, a resident town north of Boston. And lo and behold, he had recently come back from Arizona, where he was helping tidy up around his father's house. And he ended up coming to bronchoscopy, and his diagnosis was not a parasite, coccidioidomycosis.
That last story really highlights how easily it can be for us to anchor on medications. Yes, it could be the antibiotics, but my takeaway is that even if there is a common cause of eosinophilia, I should still do my due diligence and get a more complete travel history.
Exactly. So, thinking about the workup then of the infectious causes, it's going to be HIV testing, right, for everyone, stool testing for ova and parasites, and then the rest of the workup is really guided by the history and specific travel destinations. So, for example, if a patient travels to West Africa and has eosinophilia, then we should be getting specific testing for loa loa.
Yes, and then about the ova and parasites, the more days we have stool samples from, the better the sensitivity is for picking up helminths. But it's really important to know that ova and parasite is not the test of choice for strongyloides. That's because strongyloides has low and irregular larval output in the stool, so that's why we really want to get the serology.
Yes, exactly. Okay, to sum up this pearl, the next time we see eosinophilia, we want to do a thorough infectious history. It's really about where were you born? Where have you lived? Where have you traveled? Even if it was years ago, and did you have any stopovers?
And we want to really think about what kinds of food have patients eaten. Were they exposed to any undercooked or wild meats? The CDC travel website, I will link below for you guys, is an amazing resource at linking what infectious exposures are related to where in the world and when you need to think about them.
Oh, that sounds really helpful. And the last thing to round out, the P in the CAMP E mnemonic stands for pathogens. And, we can say parasites, particularly because helminths or worms are the majority of it. But we need to also remember that viruses and fungi, like, for example, coccidioides, can also cause eosinophilia.
So we covered the three big causes of eosinophilia: atopy, meds, and pathogens. Let's round out our discussion with some potpourri of high yield points on eosinophilia.
Eosinophil number fluctuates, there's a subtle fluctuation over the course of the day, which reflects the endogenous circulating rhythms of corticosteroids. You start pumping out some steroids in the morning, eosinophil tends to be lower. Also, stress can suppress eosinophil numbers. There's an old study on medical residents presenting at grand rounds and the eosinophil levels before and after. The stress of presenting at grand rounds, they were eosinopenic.
Ah, man, that is wild. So, if the eosinophil levels actually fluctuate throughout the day, what about those 6 a.m. labs that we're so used to? How do we interpret those?
So those AM labs are probably when eosinophils are at their lowest because that's when we make most of our cortisol. The rule is more stress, more endogenous corticosteroid production, the lower the eosinophil counts.
All your patients with sepsis in the hospital of neutrophilic leukocytosis, they all have suppressed eosinophil counts. I mean, like, go to the ICU census, right? Like, you'll see everyone's got a suppressed eosinophil count. Anyone who doesn't, there's probably some reason for that.
So here's the pearl. In a patient who's septic, a normal eosinophil count or a mildly elevated one is actually abnormal, right? Even though our EMR is not flagging that for us. A normal or elevated EO count in a sick patient is a clue that there might be some other underlying process.
I remember doing an ID consult and a complicated guy who had motor vehicle accident in New Hampshire, was transferred down here, was in the MICU pre-op, and sick, febrile, and he had normal U's in his diff. I said, that's curious. You always teach that sepsis and stress suppresses eosinophil. Yeah, until his CT scan showed that he had bled into his adrenals. So he had adrenal insufficiency from trauma.
I love me good Peter Weller eosinophilia story. So that patient in the ICU had adrenal insufficiency. That brings us back to our CAMP eosinophilia mnemonic. That stands for both atopy and adrenal insufficiency.
Yeah. And so in this case, with the adrenal insufficiency, there was a loss of cortisol, right? That removes that normal suppressive effect that steroids have on the eosinophil. So hence his eosinophil count was normal on the CBC.
I'm so glad we talked about stress, steroids, and how those impact the eosinophil levels. We spent a lot of time on causes, and so the next natural question for me is how do we actually manage eosinophilia?
One of the, like, really weird things about eosinophilia is that it's often easier to treat than it is to figure out what people actually have. Because honestly, steroids work for basically everything on that giant list of causes of eosinophilia.
Okay, so if steroids work so well on all our eosinophilia woes, then Sheila, why did we spend this whole episode going over etiology? I mean, I know we're good internal medicine doctors, but did that really matter?
It does matter, Shreya. We have two big reasons. First is infection. Giving steroids to someone who has an undiagnosed strongyloides infection can trigger a hyperinfection syndrome and make our patients very, very sick. The second is diagnostics. Giving steroids can really muddy the data and interfere with our diagnosis of cancers like lymphoma. They can also lead to temporary improvement in eosinophils, which can mask an underlying malignancy that's going on.
Ah, right. Yeah. Cancer was that C in the Camp E mnemonic. That's something I'm always worried about missing.
I'm also worried about it, but the good news is that it's a really rare cause of eosinophilia. There's a subset of myeloid neoplasms that we really don't want to miss, and it's one of the causes that does not respond to steroids.
Steroids will make the eosinophils go down for basically every single cause except for this one thing, chronic eosinophilic leukemia, aka MHES. And that's because in this case, these are actual clonal eosinophils. The eosinophils are part of the malignant clone. They're no longer responding to growth signals or things that try and suppress their growth, meaning they will continue to grow and replicate independent of you trying to suppress them with steroids. And they will continue to grow and replicate independent of you cutting off their supply of interleukin 5 because they are actually the cancer.
That is good to know. So then how do we think about the neoplastic workup? I mean, we're not going to be sending it off on everybody, of course.
And you definitely shouldn't. You should really think about sending it, though, when the eosinophilia is severe, like above 5,000 eosinophils per microliter or 5 in the EMR, and persistent. Eosinophilia that does not respond to steroids or eosinophilia that initially improves with steroids but then comes back with a vengeance is also concerning for malignancy.
And this is where we're like, yes, hematology or allergy immunology colleagues, please help us.
Yes, and just to give you a heads up of what their workup might include, they will probably send things like flow cytometry, fish testing for this mutation called PDGFRA, next generation sequencing, B12 and tryptase to look for systemic mastocytosis, and full body imaging.
And then I know sometimes bone marrow biopsy is part of that initial heme workup.
A bone marrow biopsy is not an essential part of the initial workup for eosinophilia. And you can proceed with just sending off all these tests off the blood.
Okay, nice. One less procedure in that initial workup for our patient. Wonderful. So I know we said hold off on steroids, right? Especially if we're ruling out strongyloides or cancer. But what if our patient's really sick and, maybe there's a concern of even end organ damage?
Like my patient who had that eosinophilic myocarditis and stroke.
For like a sick patient in the hospital who's got like an elevated troponin and an abnormal EKG, and you're like, this person could die of their eosinophilia. I do not have a week to wait for all these tests to come back. So before I'm empirically giving steroids to someone who's really sick with peripheral blood eosinophilia, I want to make sure I have a CT torso that has identified any lymphadenopathy or other possibilities of some other cancer that I want to go after biopsy before I give any steroids. I'm checking a tryptase, but I'm not waiting for the results because the reality is that's unlikely to be helpful. I am setting off flow cytometry of the blood to look for LHES, and I often will also send off the testing for myeloproliferative hypereosinophilic syndrome, aka chronic eosinophilic leukemia. And so that's going to be the translocations, the FISH testing for the PDGFR translocation, as well as doing next generation sequencing for myeloid type mutations to identify things like JAK2 mutations that may drive another subset of cases.
That was some good space repetition for the heme workup of malignant neoplasms. So, for clinically sick patients, we send off testing and start empiric steroids while we're still waiting for the results.
Yeah. And then earlier, we also discussed that giving steroids could precipitate like a disseminated hyperinfection of strongyloides. So, how do we think about that in a sick person?
My general approach is I ask the question, are there any parasites or other pathogens that it makes any sense for this patient to have? And I just think about that epidemiologically in terms of their travel and exposure history. And if there are essentially none, then I treat them for strongyloides, because everyone in the US is at risk for strongyloides, with ivermectin, and then I give them steroids. And I don't even wait because that person has this life-threatening situation. I just give them steroids and sort of like shoot first, ask questions later.
Huh. So I guess when somebody is sick, particularly if we're thinking about the patients in the ICU, I think the order of management definitely changes. And so our main takeaways when it comes to steroids and malignancy, we know steroids is an effective treatment for lowering eosinophils, but there's a worry of the hyperinfection of strongyloides and also reducing our diagnostic yields in neoplasm like lymphoma.
And one of my absolute favorite pearls is that in critically ill or septic patient, a normal eosinophil count is actually really abnormal and should make you concerned about causes of hypereosinophilia. That could be anything that we just talked about, like drug exposures, adrenal insufficiency, et cetera, et cetera.
Coming back full circle, everything we just talked about. So that is a wrap for our episode. I hope you guys had fun taking a trip on Camp Eosinophilia with us. Gila, thank you so much for putting this together and leading the ship. I learned a ton.
Thank you so much, Shreya. And if you want to add any of your own tips, listeners, please leave a comment on our website page on Instagram or Facebook. Thank you so much to our peer reviewers, Dr. Panise Curry and Dr. Jonathan Berry.
And always, we love hearing feedback. Please email us at hello@CoreIMpodcast.com. Opinions expressed are our own and do not represent the opinions of any affiliated institutions. Thank you and take care. Because
the deeper your learning gains.
People meet me at conferences and then they like quote that to me.
The more you test yourself, the deeper your learning gains.
So it's embarrassing, but then I'm like, okay, now if
that's not a bad tagline.
I'm such a nerd. Like that make
there
it
are worse.
I know. Well, Gila, if you have other ideas, I welcome new branding.
No, I like this.
Okay.